Peripartum depression is a massive challenge, not just for our patients, but for us as clinicians too. So in this explainer, we're cutting right to the chase. We're breaking down the latest evidence-based guidelines into a clear, actionable framework you can actually use in your practice.
So, what does a truly effective evidence-based approach to PPD actually look like? From prevention all the way through to treatment. Well, that is the big question we're going to answer today, giving you the direct guidelines you need to feel confident in your clinical practice. Here's how we're going to break it down. First, we'll talk proactive prevention. Then we'll get into screening and how to catch it early. After that, we'll cover treatment protocols, both during pregnancy and postpartum, and we'll wrap it all up with the key clinical takeaways you can start using right away. All right, let's dive into our first section. Look, the best management strategy is one that starts before PPD even has a chance to take hold. This is all about spotting those at-risk women early and putting proven preventative strategies into play. So, right from the top, the guidelines are super clear on this. What we should be doing is actively using psychological and psychosocial interventions, and of course, encouraging physical activity. And what we should not be doing, using antidepressants as a preventative tool or banking on dietary changes, where the evidence just isn't strong enough. So what does this look like in the real world? Well, the evidence gives a huge thumbs up to things we know work, like CBT and interpersonal therapy. But what's really fascinating is that it's not just about therapy. It's also about crucial structural supports, things like professional home visits, redesigned postnatal care from midwives, and even telephone support from trained peers. And when we talk about physical activity, we're not just being vague. We have a specific target, at least 90 minutes a week. And listen, this isn't about running marathons. We're talking about beneficial activities like stretching, Pilates, and aerobics. It's a simple but really powerful prescription. Now, this focus on prevention flows perfectly into our next phase, screening. Identifying PPD early is absolutely critical, but the guidelines get very specific about when, how, and most importantly, under what conditions we should even be doing it. The evidence points to two prime windows for universal screening. First, during mid to late pregnancy, and then again at the 2 to 3 month mark postpartum. If we hit these 2 points, we give ourselves the best possible shot at early detection. And this brings us to a point that I cannot stress enough. The guidelines are adamant. Screening in a vacuum is just plain irresponsible. We should only be screening for PPD if we actually have the system in place to do something about a positive result. So, what does an adequate system really mean? Well, as you can see, it is way more than just a questionnaire. It means having clinicians who are properly trained, having immediate crisis intervention available, having clear, established pathways for diagnosis and treatment, and using psychosocial tools to see the whole picture of risk. Okay, let's shift gears and talk about treatment when your patient is currently pregnant. This is where we have to perform that really delicate balancing act between maternal mental health and the well-being of the fetus. The main recommendations here are pretty straightforward. Cognitive behavioral therapy is your frontline approach. For severe cases, antidepressants are definitely recommended. And for those therapy-resistant, life-threatening situations, ECT is a key option. But the don'ts are just as critical. Don't just stop meds in high-risk patients. And always screen for those exercise contraindications. When you do prescribe antidepressants during pregnancy, this 4-step protocol is your roadmap. You start with a careful risk-benefit analysis. Then you aim for monotherapy at the lowest effective dose. And this last one is crucial. Regular therapeutic drug measurements are recommended. Why? Because a woman's body goes through huge pharmacokinetic changes during pregnancy, and this helps us keep the dosing just right. I really want to hammer this point home because it's a critical patient safety issue. If you have a woman with a history of severe recurrent depression and she's stable on her medication, discontinuing that treatment just because she's pregnant is not the recommended path. The risk of relapse is just way too high. So while we're encouraging physical activity, it's our job to counsel patients on the contraindications and the warning signs. Exercise is a no-go for conditions like significant heart disease or preeclampsia, and it needs to be stopped immediately if any of these red flag symptoms pop up. Okay, moving into the postpartum period. This is where our toolkit of evidence-based interventions really expands. Let's take a look at the recommended protocols for treating PPD after the baby arrives. Now, what's really cool here is just how broad the options are. We've got newer drugs like brexanolone, which is known for acting much faster than traditional SSRIs. We have neurostimulation alternatives like RTMS, and we also have strong recommendations for things like music therapy and structured peer support. It's a whole toolbox.
It's just as important to know what to steer clear of. The guidelines are explicit about St. John's wort. It can cause genuinely life-threatening interactions with antidepressants. And, while yoga might be great for other things, there's just no evidence right now that it helps with PPD symptoms specifically.
Wow, we've covered a ton of ground. So let's boil it all down into 4 essential takeaways, the core ideas you can take with you.
First up, prevention is all about being proactive. Use therapy and recommend exercise. Do not use antidepressants to prevent PPD. Simple as that.
Second, screen, but screen responsibly. Don't even start a screening program unless you have the whole system ready to go, from diagnosis all the way through treatment for anyone who screens positive. Our third big takeaway: when you're treating during pregnancy, stability is king. For those women with a history of severe, recurrent illness, do not stop their medication. And finally, for postpartum treatment, embrace all the evidence-based options we have, from new drugs like brexanolone to good old peer support, but be extremely cautious with supplements like St. John's wort. So I'll leave you with this final thought. As you think about your own practice, your own workflow, which one of these evidence-based guidelines gives you the biggest opportunity to make an improvement starting tomorrow?